Welcome back to another incredible episode of Mind Matters, Navigating Head Injuries and Concussions. My name is Kylie Como. I'm the in-house legal nurse consultant here at Shane Smith Law. Today we have back with us Dr. Bashik from the Concussion Center in Atlanta, Georgia, for the second part of our discussion on concussions and the management of these injuries. If you didn't have an opportunity to catch the first part of this discussion, I would highly encourage you to do so, as it's going to provide you with a great deal of knowledge and insight that's going to add to your understanding of our discussion today with Dr. Bashik. All right, Dr. Bashik, if you don't mind, let's jump right into your presentation, if you would.
Again, concussion is an osteoplastic disorder due to central sensitization, part 2. In part 1, we went through these 8 definitions: concussion, persistent post-concussion symptoms or post-concussion syndrome, pain, nocioplastic disorder, cortical spreading depression, central sensitization, microglia, and the lymphatic system. And I know Kylie mentioned this, but I strongly recommend you see part 1 before you move forward. We have the same objectives: explain how concussion should be considered as part of a new pain disorder, a nocioplastic disorder, describe the need for a sense of urgency in concussion management in hopes of preventing persistent post-concussion symptoms, describe the similarities of concussion, migraine, and whiplash, and update the management of concussion and persistent post-concussion symptoms. So if you think about persistent post-concussion symptoms, again, these are symptoms that have gone on after a month from the initial impact. If you think about PPCS as a form of nocioplastic pain due to central sensitization, it reveals a time-dependent process that potentially can be interrupted. And recognizing this temporal dimension is key because it points to a critical therapeutic window for early intervention. And the goal, the strategic goal, is to prevent neuroplastic changes that are responsible for this pain chronification. And if you think about it, that's what we do with migraine. We want to treat the migraine early because we don't want that person to develop a chronic migraine. We want to try to treat it early, end it as quick as possible so they don't get an opportunity to develop central sensitization and nocioplastic pain. Persistent post-concussion symptoms as a nocioplastic disorder. So again, this time course pattern correlates with the development of nocioplastic pain and the phenomenon of central sensitization. If symptoms linger, central neuroplastic changes occur and the symptoms become chronic. And earlier we talked about, in part 1, we talked about the person who had a back problem and he had a herniated disc, and then he goes and he has surgery and the disc is removed. Well, if he waits too long, and it's different in different people, but sometimes if you wait too long, that disc is removed, but that person can still be left with pain. So you don't want the symptoms to linger if you can help it. So this underscores the notion that there's a therapeutic window for conservative interventions, early period. This closes once the neuroplastic changes and central sensitization have become established. So earlier the better. And that's the way it is pretty much with everything in medicine. The sooner you go after it, sooner you get treated, the better chance you have of getting better. Multiple studies demonstrate that early proactive care significantly improves concussion outcomes. Think about the Buffalo concussion treadmill test. We want that started on day 2 or 3. We want to help improve that autonomic nervous system dysfunction. We want vestibular ocular motor therapy as soon as possible. We want cervical therapy as soon as possible because these can all lead to central sensitization and nocioplastic pain. So there are 5 components of central sensitization specific to concussion that can be targeted with treatment. And so we're going to go through all 5 of these. So the first one is peripheral sensitization. The sequence begins with an insult, trauma to the head, neck, or body. This triggers the peripheral nociceptors. This is peripheral sensitization. This is marked by heightened responsiveness and excitability of these nociceptors, these little nerve endings in your skin or in other parts of your body. Microglia become activated by something called CGRP, calcitonin gene-related protein. And this results in neuroinflammation, neuronal sensitization and the beginning of the neuroplastic changes. CGRP is a very important chemical. This is the this is the compound that all the new migraine medicines are used for. All the migraine medicines now, the Ubrelvy and the Nurtec and Amavig, Emgality, Ajovy, Vyepti, Qilepta, all of these drugs reduced CGRP levels, and that's how they work. And so we use a lot of CGRP medications or anti-CGRP medications. Once these neuroplastic changes occur, they amplify the pain signals, and the cumulative result is CNS remodeling or neuroplasticity, leading to pathologically elevated pain and sensory hypersensitivity, and now it is independent of the original source of the peripheral injury. So what can we do to help reduce peripheral sensitization? We can reduce it by reducing CGRP levels, by using CGRP drugs. I use CGRP drugs in as many people as I possibly can because they are so beneficial. They're so helpful in reducing neuroinflammation, helping the headaches. So I strongly recommend that these medications are used early. Guess what? Exercise. I've already talked about the Buffalo Concussion Treadmill Test, but it is well known early exercise has revolutionized the treatment of concussion. There's no more cocooning. We recommend relative rest for 1 to 2 days. But after that, it needs to be exercise, but it has to be done exercise in the right way. You can't just go out there and run as fast as you can or as long as you can. It's all about getting it having the proper heart rate. And so that's based on age. And so we always have that person come in the office. We do the Buffalo Concussion Treadmill Test or the Buffalo Concussion Bike Test, and it's all about their heart rate. And then once we do it in the office, we show them how to do it. They go home and they do it. They go to their gym or their house and they do it 4 to 5 times a week. It helps correct the autonomic nervous system dysfunction that occurs after in so many people with concussion. But it has to be done right. And so it needs to be under medical supervision. And even if you don't have access to a treadmill or bike, there's a walking protocol that we use. The walking protocol is not as good because, and again, I'll just say, because here we live in the Atlanta area, what does it do here a lot? Well, it rains. So people aren't going to go out there when the weather's bad. We also have a lot of hills, so I don't like hills. And then, you know, if you're walking on the street, you got to watch for vehicles. You got to watch for critters. Your neighbors will want to come and talk to you. That's not what you want to do when you're doing the exercise, the walking protocol for concussion. You don't want to stop and chat. And I'm going to come back to exercise with every single one of these things I'm going to be talking about for the next few minutes. Analgesics, anti-inflammatories, Tylenol, they help reduce peripheral sensitization. Not that much, but every little bit helps. Physical therapy, okay? Vestibular therapy, cervical therapy. The sooner, the better. All right, we're going to now go to the next one, which is cerebral metabolic dysfunction. Now, we've talked about this earlier with this neuronal excitation followed by depression, okay? Cortical spreading depression, we've talked about that. All right, that occurs in the first week after the injury. This is the window of time where symptoms are the most severe after the concussion and when central sensitization begins. So the mitochondrial dysfunction lasts for 3 to 6 weeks. This results in the temporary energy deficit or 20% drop in ATP production. So what can we do to help this? How can we help the mitochondria? How do we support the mitochondria? Early mitochondrial dysfunction is seen in acute mild traumatic brain injury. So creatine supplementation. Everybody knows about creatine. Creatine is used for bodybuilders. Okay, well, that's not what we're talking about. Creatine increases ATP in cells, in all cells, muscle cells, but also brain cells. And what we're trying to do is increase ATP in the brain cells, make the mitochondria work better. CoQ10, vitamin D, and guess what? Exercise. Buffalo Concussion Treadmill Test, Buffalo Concussion Bike Test. Get out walking. This helps your mitochondria. This helps you recover. Neuroinflammation. Neuroinflammation is a pivotal component in the initiation of nociceplastic pain after concussion. In traumatic brain injuries, CGRP amplifies the microglial response. It primes the neurons for neuroplastic changes in the trigeminal system or the fifth cranial nerve. CGRP levels increase after concussion. CGRP levels increase in migraine. And that's why CGRP drugs work with concussion. Even though they're not FDA approved for concussion, I mean, there's no medicine that's approved for concussion. Everything's off label, but CGRP drugs work very well for headache in concussion. Targeting neuroinflammation early after concussion injuries may disrupt the cascade of events and potentially prevents persistent post-concussion symptom development. So what do we do to decrease neuroinflammation? I use omega-3, 1100 milligrams twice a day. Okay, omega-3 is a very good anti-inflammatory. Omega-6 is very inflammatory. American diets got a lot of omega-6. Omega-3 is smash, salmon, mackerel, anchovy, sardines, herring, fish. I use a lot of vitamin D. CoQ10, melatonin for sleep, curcumin, exercise. Imagine exercise helping. Buffalo concussion treadmill test. How many times do I need to say that?
Sounds important.
It's important. And here we go, glymphatic system. The glymphatic system is linked to sleep and the circadian system, with over 80% of glymphatic system clearance occurring during deep sleep. It's important to sleep because sleep is also pathologically disturbed after concussion injuries. Circadian therapy interventions are important early interventions. Imagine this, exercise is helping. I'm not going to say it again, but omega-3s help with the glymphatic system. Melatonin helps with the glymphatic system. Blue light therapy during the day helps the glymphatic system. Pain catastrophizing. Attitude matters.
Yeah.
Pain catastrophizing involves an exaggerated negative mental outlook toward pain, magnifying its threat, fostering feelings of helplessness, and contribute to increased distress and disability. That's why it is so important that early on, that first person, that first healthcare provider the patient sees, they need to know that a concussion is a temporary energy deficit. They will get better. But if they don't know that and all they see is stuff on television about football players getting CTE and dying and all this stuff, they don't know what to think. And so it's really important that they get good information early on. So central sensitization is a paradigm shift in understanding and managing chronic pain. It provides a common mechanism that explains a lot of persistent pain conditions and various clinical presentations, and including a lot of the comorbid symptoms. Central sensitization is adaptive in the short term, but it's maladaptive in the long term. Your question earlier, Kylie, 8 specific disorders related to central sensitization are suggested to be restless legs, chronic fatigue, fibromyalgia, TMJ, migraine, tension headache, irritable bowel syndrome, multiple chemical sensitivities, whiplash. Non-specific emotional disorders related to central sensitization include anxiety, panic attacks, depression, and I think concussion and persistent post-concussion symptoms should also be included in nociceplastic disorders due to central sensitization. So what do we do? This is what we do at the Concussion Center. These are things that we do. Number 1, shocking, exercise, subsymptom threshold aerobic exercise, the Buffalo Concussion Treadmill Test, Buffalo Concussion Bike Test. There's a walking program. Not everybody can do it. Okay, there are times where you can't. You got a fractured ankle, you're not going to be able to do it. You only have one leg, going to be difficult. Okay, you can do it. Some people have the elliptical. Some people have a rower. Yes, it can all be done on that. Okay, so exercise is one of the mainstays now for people getting better, but the exercise must be done properly. If you do too much, it actually makes it worse. We do ocular motor vestibular testing and rehabilitation. We have this ocular motor test called Neuroflex. that measures your eye movements very precisely. You can see this in people who've had concussions, and I really feel like this test, this NeuroFlex test that we do, is the test that needs to be done before you return to play. Not necessarily, not everybody's return to play. Okay, if you're in a motor vehicle accident, return to play is not the issue. All right, if you've been assaulted, okay, and you're 75 years old, return to play is not an issue. So again, not everybody are we concerned about return to play, but return to normal activity. A low inflammatory diet. Primary care doctors can really help with that, emphasize that. A low inflammatory diet, high in omega-3, high inflammatory diet, which is high in omega-6, which is fast food. It's food that sits on your shelf. Omega-6 can make concussion symptoms worse. I use a lot of anti-CGRP medicines. They're awesome, okay? I often use omega-3, creatine, vitamin D, melatonin, theanine, B12, ashwagandha. So supplements can be very helpful. I do something in the office. We don't do it actually in the office. I order it, but most people go to the lab to get it done, obviously. I call it concussion blood work. There's no such thing as concussion blood work. I made that up. And basically what this is blood work where we see a lot of abnormalities who've had head trauma. I can't tell you how many people I see with low vitamin D, low omega-3, low B12 levels, elevated ferritin levels, low iron levels, and all of these things will contribute to persistent symptoms. And they're easy to fix. We do general cognitive testing. We do cognitive driving evaluations. We do auditory processing evaluations. And I have a little notebook in the office for education that people can look through. They can copy it. Take pictures of it just to try to give them, because education is a very important part of what we try to do. So this is concussion blood work. All right. Most of the time, if somebody's been to the primary care or the emergency room, usually a CMP, which is metabolic panel, the CBC, your blood count. Those have usually been done. If they haven't, I will do them. But I order B12, iron studies, thyroid, vitamin D, omega-6, omega-3 ratios, homocysteine, and others. But those are the main ones. So in conclusion, I think concussion, whiplash, migraine are nocioplastic disorders due to central sensitization. There needs to be an urgency in concussion management to try and help prevent or reduce persistent post-concussion symptoms. I think we can, if the current rate is 25, 30%, I think if people are treated more on an urgent level rather than, just go rest. Yeah, I think if we treat it with some urgency and get treatment started early, I think the number of people with PPCS can be reduced dramatically. The management for acute concussion and persistent post-concussion symptoms is multifaceted. Yes, I have emphasized exercise so many times today, absolutely. But there's more, okay? You need to think about the neck. You need to think about ocular motor, vestibular, diet, hormonal. You need sleep, anxiety. All of these things need to be addressed. Thank you very much.
So Dr. Bashik, thank you. That was fantastic. What a deep well that was. I want to dig into some of that. So this whole idea of a concussion being a nociplastic disorder is truly fascinating. So, it really does change how we think about this, as well as the other nociplastic disorders you kind of touched on. You previously discussed, if our listeners went back and listened to our first one, the nociceptive pain, or that pain that's caused by tissue damage or whatnot, the neuropathic pain, that nerve damage pain. But this category of nociplastic pain, or I think you call it the central sensitization model, talk about, again, tell them what somebody should look for if they have to go to, say, the emergency room and they have a concussion.
So in the emergency room, the ER docs, they are always concerned about ABCs first, airway, breathing, circulation, and they always want to rule out the red flags associated with concussion. But once we have a stable situation, it really helps if they begin the process of talking about exercise done in the correct way as a major aspect of concussion recovery. You don't want to be cocooning. You want to get out and be active. I think they certainly could begin anti-CGRP medications if headache is a big complaint. They can certainly start with some of the supplements, omega-3, vitamin D, melatonin, creatine, and then educate this patient. Concussion is a temporary energy deficit that lasts for 3 to 6 weeks. The number one predictor of a short recovery is actually being seen by a healthcare provider that is knowledgeable in concussion care, and then starting treatment as soon as possible.
Okay. I think you bring up a good point. You said it, emergency medicine is really more about stabilization, right? And providing that immediate care for those life-threatening situations. And I completely appreciate that this would probably be the ideal time to really lay that groundwork for ensuring that effective long-term concussion treatment through that education, right? That the patient on what to look for in the coming weeks and months. So to that, when they leave the ED, usually there's a follow-up. They tell you to follow up with your primary care physician in a few days. What would you tell your patient to look for at that visit?
Well, I want to go back to something that you just said, and I do agree with you. I will tell you that I gave an in-service to some of the emergency room doctors at Piedmont a year or so ago, and we actually started getting people come to our office expecting to exercise, and that made it so much easier. The person was ready, was motivated, and ready to go, and those people did really well. When they get told to rest, and then I go and I tell them to exercise, it causes a lot of confusion. So starting this whole idea about exercise early makes a big difference. But in the primary care office, again, these folks like I often do get and can get anti-CGRP medications as samples. So if headache is a big problem, I recommend they start using some of the CGRP drugs because they're just so safe. Okay, they're not controlled substances and they work so well. Triptans can be used as well. Non-steroidal anti-inflammatories can be used as well. I always try to use samples and provide coupons because the CGRP drugs are expensive. I like, with the primary care doctor, if he starts talking about exercise, that helps us if they come to us. And again, they can certainly, based on the phenotype of the person, provide supplements. If the person's having sleeping issues, omega-3 and melatonin. If there's a lot of fatigue when they come in, well, creatine, we use a lot of that. So they can do education, they can do CGRP drugs, they can provide supplements. So the sooner they get moving with that and bring that up, the better it is for everybody.
Yeah, 100%. Preparation is the key for sure. You mentioned, we've been talking about headaches a lot. It's one of the key symptoms that everybody associates with concussion. I know here at the firm, the vast majority of our clients that come in with, mild traumatic brain injury or worse, perhaps, have a headache as one of their symptoms. So how often would you say you see that in your practice, that headache as a symptom of concussion?
So headache as a symptom of an acute concussion occurs in about 80 to 90% of the patients. It usually begins immediately, a few hours later, the next day, but that is typically the major component that the patient has. And when you have a bad headache and it doesn't go away, doesn't respond to Tylenol or anti-inflammatories, makes it hard to sleep. Well, guess what? If it's hard to sleep, you're going to get neuroinflammation. You get neuroinflammation, okay, your lymphatic system's not going to work. You're going to get more neuroinflammation. You get more headaches, more insomnia, brain fog, and it's just a vicious circle. So the CGRP drugs, they are just spectacular. Okay, they've been around for about the last 5 years. There are about 10 of them now, and we know that CGRP is elevated with migraine. We know that CGRP is elevated with concussion. We know there are no FDA-approved medications for concussion, but just because it's not approved doesn't mean that it doesn't work, and it does work. Everything with concussion in terms of medicine, off-label.
Yeah, such a new and ever-expanding area. That CGRP, was it calcitonin gene?
Calcitonin gene-related protein.
Yeah.
And these drugs, they tend to reduce the frequency and severity of the headaches. They reduce the light and sound sensitivity, nausea. They sleep better. Well, guess what? When you sleep better, your lymphatic system's better. There's reduced neuroinflammation. They're incredibly safe. Again, I said this earlier, they're not controlled substances. At the concussion center, we get samples all the time. Again, the downside is cost and getting insurance approval. But I will tell you something, Kylie. Earlier this year, in March of 2014, the American Headache Society recommended CGRP drugs as first-line treatment for migraine. And so we use a lot of them. And I encourage anyone who takes care of a post-traumatic headache to consider using these if it's possible. One of the drugs I like is Vyepti. Vyepti, it's an interesting drug. It is an anti-CGRP drug. It's given IV, okay? So that's one of the issues with it. It's given IV. And it's supposed to be used as a preventative, not for acute treatment. But there are studies actually that show that it's beneficial acutely. And so if it's going to benefit someone acutely and preventatively, and it lasts for 3 months, so that's the difference. Okay, the Ubrelvy and the Nurtec, were 24, 48 hours. The Amovig, Emgality, Ajovy, the injections usually last for about a month. The Vyepti lasts for 3 months. Well, if you're in the emergency room and you got an IV in because you're getting hydrated because you had a concussion and you got a bad headache, well, what if what if somebody got Vyepti?
Right.
And it's so safe. I think that is something that could prevent a lot of misery. We give Vyepti IV in the office. Okay, we give a fair amount of it, and we've had very good success with it. So I'll just put that out there. Okay, it's not it's not a FDA approved for acute treatment, but there are studies that show that it's beneficial. And at the Concussion Center, our motto is evidence-based care with a growth mindset. And so, I'm always looking for something that we can help people in a better way.
I love that evidence-based care with a growth mindset. That's perfect. I wish we would all take that approach, but I know there's got to be safety. We've got to move things slowly and make sure, we're talking about people's lives, but I can definitely appreciate that attitude. I think I'd like to kind of finish with, it's kind of a two-pronged question. And you kind of touched on a little bit in your last part, and you got me thinking about, avoidance. How can we put ourselves in a position to where maybe we can avoid or mitigate some of the likelihood of incurring a concussion. So question being, what's the importance of pre-existing conditions in concussion recovery? And then also someone's pre-existing fitness level, for example. How important are those two things?
So very, very important. So what you bring to the table really matters. So if you have a lot of pre-existing conditions such as anxiety, depression, chronic pain, a negative attitude, or the failure uniform, recovery is going to be a lot harder. If you eat a high inflammatory diet, you have low B12, omega-3, vitamin D, it's going to take you longer to recover. If you're on chronic opioids for chronic pain, it's going to take it longer to recover because you probably have central sensitization and a nocioplastic disorder, and now you're adding on to that. So that definitely can make things worse. So what you bring to the table definitely matters, and your fitness matters. There's a reason why elite athletes tend to recover faster than everybody else. And I think that has a lot to do with their mitochondria. They are elite athletes, and you don't necessarily have to be an elite athlete, but if you're just in good shape, okay, if you're not heavy, you are exercising your mitochondria. You're making them become more efficient. And so even when you have this decline in mitochondrial function by 20%, if you have more mitochondria, more efficient mitochondria, then you're going to recover faster. If you are overweight, if you do have a bad diet, you will still recover, but it may just take longer.
Takes longer. Yeah, that makes sense. It's the old adage, if you don't use it, you lose it. I guess that gets down to the mitochondria level too, huh?
It absolutely gets down to the mitochondria, and that's a whole other lecture, actually.
All right, man, there you go. We'll have to put that one on the books then. I've got one more thing I'd like for you to address. Can you kind of give our audience a rundown on any of the differences that men versus women might see with regard to concussion?
So Men tend to certainly have more concussions than women because they put themselves much more at risk. So there are a lot more men that play sports than women, and men tend to be in the jobs they take. They're at greater risk in general compared to women. But if you do take a look at sports where women and men are equal, so for example, basketball, soccer, that type of thing. If you take equal sports, you'll see that women actually have more concussions than men. And the reason for that is not totally clear. There are three ideas about that. So one is men in general are going to have bigger necks than women. So if you think about concussion as being acceleration, deceleration, if you have more muscle mass, your acceleration, deceleration may be less with the same force. And so the women who tend to have smaller necks, the more flexible necks, they may have more acceleration, deceleration. So that may be one reason why they're at greater risk. Another reason, it could be hormonal, estrogen, progesterone. And then the third reason, which I do think is a very valid reason, is women tend to tell the truth more. Okay. So, I don't know. Is it one of those? Is it two of those? Is it all of those? Is it something else? I don't know the answer to that. I think it's probably a combination of all three, actually.
I would agree with that. Well, Dr. Basham, as always, it's been a real pleasure speaking with you today. I really do appreciate you taking the time to share your knowledge and your expertise with all of our listeners. And I'm looking forward to the next time we get to sit down and have some more discussions like this.
Well, Kylie, thank you very much for having me. And I also look forward to the next time we do this. Thank you very much. You have a great day.
Okay, everyone, that's going to do it for another episode of Mind Matters, Navigating Head Injuries and Concussions. We hope that you found this discussion informative and interesting. Please be on the lookout for future episodes as we continue to dive in on the fascinating world of head injuries and the amazing work being done to understand and navigate these types of injuries. Please remember to hit that like button, and if you're not already, subscribe to our channel to keep up with our latest and greatest content. And as always, if you're in pain, call Shane at 980-999-9999. Thank you.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.